In celebration of the 108th foundation of the UP College of Dentistry, the UP Dental Alumni Association presents Clinical Protocol Updates. Hello everyone, I am Dr. Monica Kiambao from the UP Dental Alumni Association, and I am here with co-alumnus and the chair of the PDA Science Committee, Dr. Lisa Centeno.
Hi, Dr. Monica. Hello, everyone.
Dr. Lisa, with the vaccinations, the decreasing number of cases, and the milder symptoms experienced by COVID-positive patients, we have seen several COVID-related restrictions being lifted by the government, and we see our fellow Filipinos are enjoying these. May we ask, for our dental profession, what has changed with our clinical protocol guidelines?
Yes, we need to establish first that SARS-CoV-2 is still very much around. At bukod doon, hindi lang naman sa SARS-CoV-2 tayo dapat mag-ingat. We need to remember that there are other pathogens that's still floating in the air and we are susceptible to getting infected from. We have hepatitis A, we have tuberculosis, and we do know tuberculosis, primary complex, they're endemic in the Philippines. So we still need to take care of ourselves from those things. So we must remember that it's not just the SARS-CoV-2.
Thank you. Let's discuss that in parts, starting with patient screening and scheduling. Dr. Lisa, are the following steps staying or going? Number 1, telescreening.
Telescreening should stay. I think it's a very efficient way of addressing what the patient needs and mitigating infection in the dental office.
Number 2, contact tracing forms.
Contact tracing forms, yes, you can do away with that. Hindi na natin malaman kung saan ang galing, so there's really no use doing that.
Okay, how about deferring treatment for a symptomatic patient?
Yes, we should defer patients who are symptomatic because we still want to protect ourselves.
How about antigen testing prior to aerosol procedures?
Depending on the case that you are doing, if you're anticipating a very long aerosol generating procedure, then you can ask for a SARS-CoV-2 test.
How about asking the patients to present their vaccination cards?
No, vaccine cards, no need.
How about temperature and O2 saturation checks?
Temperature checks is still a good deterrent. It can still check if the patient has a fever or not, and it can be a deterrent. While O2 sat is not necessary, oxygen saturation testing is not necessary, especially for non-symptomatic. It's only necessary for those who are sick with SARS-CoV-2 or COVID, and sometimes not all patients also manifest decrease in oxygen saturation levels.
Let's move on to the dental treatment procedures. So are the following staying or going? Pre-treatment oral rinse.
There are several RCTs now, randomized controlled trials that showed significant reduction in the viral load. I have to say that Cochrane has reviewed that it has very low evidence, only because they are looking for a correlation between the reduction in the viral load and the decrease in susceptibility for infection. We have established that aerosol in the office is like you're like bathing in the pathogens. Okay, so when you have aerosol production in your clinic, the moment the child cries is already an AGP. So if you have a pre-procedural mouth rinse, the RCTs are now showing 30-second rinse, 30 to 1 minute rinse of different types of measurements, of mouth rinses, of mouthwashes, can actually reduce the viral load significantly. What the randomized controlled trials have proven is that if a patient with tested positive for SARS-CoV-2 in an RT-PCR test, there is a significant reduction of the viral load immediately to a max of 6 hours. We can keep the pre-procedural mouth rinse for our own safety. It's like my good friend always compares this, the analogy of not everything should be RCT or not everything should be evidence-based. Let's say you want to jump from a plane, will you jump with or without a parachute? Diba? Nobody has proven that you will survive without a parachute. But everybody uses a parachute anyway. Parang ganon lang yan.
Next would be level 3 PPE.
Staying. As I said, we're bathing in pathogens. So we'd like to be protected as much as possible. We're talking about our personal protective equipment, specific equipment, especially our face shield. That should not go away. We have proven that spatter, the clinician, and the first assist are the most susceptible to spatter and aerosol. So we want that protection.
How about PPEs on the patients?
Again, we need to qualify what type of PPE are we talking about. When we say bib or maybe a hair cover, then they could stay.
The additional infection control fee, should it stay or should we lessen?
Definitely stay, because we let's remember that the infection control fee is not only your mask, your gloves, and your head cap. And your gown. It's also your means of disinfecting your operatory. It also means using all the barriers that you need to use, and the use of autoclaves, the use of disposable materials that and the burrs, the instruments, your files that you need to throw away per patient. That should still go. I mean, that's still part of infection control. And it's still really up to you how you want to incorporate it, whether it's incorporated in the procedure or you want to make it like a separate fee.
So let's go to airflow controls. Are the following staying or going? Number 1, plastic barriers.
Yeah, the plastic barriers have gone a long time ago because the infection probability or your susceptibility to get the infection depends on the dose. Dose means the viral load and the concentration and the time. The time is how long ka nakababad dun sa aerosol, a dirty air. We call it dirty air because the saliva is a house, a haven for pathogens. So the saliva has bacteria, fungus, you have fungi and virus. So it's really dirty. So naliligo tayo sa pathogens. So we don't want to be confined in that plastic barrier. That's why we want to aerate the clinic as much as possible. So again, your infection probability is dependent on the dose. That means dose and concentration plus the time.
Yeah. How about aerosol suctions?
Aerosol suction is another means of reducing aerosols in your clinic. It's a way of cleaning air in the operatory. If you have poor ventilation, let's say your facility is in a condo or in a mall wherein you don't have enough windows for good ventilation or introducing good air, then you might want to consider still using your aerosol suction. Every little thing can help.
How about exhaust fans?
Exhaust fans, definitely. They're a very good way of driving away or cleaning out bad air, and this has been used in hospitals for a very long time. So yes, you need to make sure that the exhaust fans are computed according to the size of your clinic and the number of people in the operatory at a given time.
So with air purifiers,
in the waiting area. In the operatory, it might not have much use depending on the type of purifier that we have or that you're using, because there are purifiers that absorb air from the bottom of the machine, and they release on top, and some of them revolve. So imagine if you are on the dental chair and the purifier is at the floor, and your aerosol is at the level where they are constantly agitating the air. Hindi na absorb at the bottom kasi yung splatter na lang bumababa, di ba? So the air is not absorbed at the bottom, but it only circulates it. The more it agitates the aerosol. So what you can do is to probably put it up, elevate, so that it will absorb, but it also doesn't absorb much, unlike your suction devices. Mas malakas mag-suction yon than your purifiers. So that's why I said, so maybe sa waiting area.
And the recommended time interval between patients.
Okay, we still do clearing, because what we want to do is clear out your bad air and introduce cleaner air. The interval could be 10 minutes or even less, for as long as you can aerate faster. You can probably use a counter. There's a counter that monitors the carbon dioxide. That's the closest that we can monitor.
With UV lamps, are they still recommended?
In our clinics, you can still use that if you have it, but just be cautious, because we know that it's very harmful for the eye and it contains compressed mercury.
Let's go to the updated recommendations for quarantine, beginning with the recommended quarantine period for COVID-positive patients.
The latest recommendation that I've seen internationally is 5 days, for as long as you have no more symptoms and you have no fever for at least 24 hours. In most cases that we see now, it's quite mild, so you can just rest for like 5 days, and then if you have no more itchiness or you have no more symptoms, then you can go out and work.
And what are the recommended quarantine days after an exposure for vaccinated and unvaccinated persons?
If you're a health worker, I think you just need to observe yourself. If you have a close contact, there are again qualifying. Are you unmasked? Did you eat together? How long was that? Was it less than 15 minutes? So these are the key elements that you need to think about.
Do you think online consultations are still a good practice these days and in the future?
Yes, I think so. It should stay. It makes our practice efficient.
Any final message, Dr. Lisa?
Okay, I think since 1891 or the 1800s, we know already from Professor Willoughby Dayton that the mouth is a plethora of pathogens. So whether it's a new virus or a virus that's been here for decades, we still need to protect ourselves. There are measures for us to do that. And we should understand that it's not just ourselves that we need to protect. It's also the people around us. It's also the people we love and we go home to. So we don't want them we don't want to be the reason for their disease.
Thank you very much, Dr. Lisa, for these very important updates. This reminds us that we should never let our guard down, especially in the practice of our profession. Mag-ingat po tayong lahat. Ito po si Dr. Monica mula sa UPDAA. ang inyong mga dentista para sa bayan.